Urinalysis is one of the most underrated diagnostic tests in veterinary medicine. It's cheap, fast, and packed with information, but only if you read it systematically. Today we're going to treat urinalysis as a three-part exam. Each part asks a different question about the urinary system. By the end of this talk, you'll never look at a urine report the same way again. A complete urinalysis has three parts, and all three need to be done together. The physical properties give you a first impression. The dipstick chemistry tells you about dissolved substances, things being lost or retained in the urine that shouldn't be there, or absent when they should be present. And the sediment exam is like looking through a microscope at what's physically present in the urine. Cells, bacteria, crystals, casts. Skipping any part is like reading only one chapter of a book. Always do all three. Before you interpret a urinalysis, you must know how the sample was collected. Cystocentesis, using a needle to go directly into the bladder, gives you the cleanest sample, free of urethral or external contamination. It's the gold standard for any culture and for interpreting sediment findings. A free catch sample collected from the floor or a cup is going to have environmental bacteria, epithelial cells, and debris that have nothing to do with the urinary tract. If someone hands you a urinalysis report without recording collection method, that's a problem. Always ask. First thing you do with a urine sample is look at it. What color is it? Dark amber usually means concentrated urine, which is appropriate in a dehydrated or mildly ill patient. Pale and watery in a sick dog is a red flag because it tells you the kidneys aren't concentrating despite the body needing them to. Red or brown urine can mean blood, free hemoglobin, or myoglobin, all of which need to be sorted out with the dipstick and sediment. Cloudiness suggests something is suspended in there. Cells, crystals, bacteria, and the urine-specific gravity, always measured with a refractometer, never trust the dipstick for USG, is the most important single number in the whole urinalysis. The dipstick is your dissolved substance panel. Let's hit the highlights. Protein. A small amount in concentrated urine may be insignificant, but protein in dilute urine is meaningful. Always follow up suspicious proteinuria with a UPC ratio. That quantifies how much protein is being lost. Glucose in the urine without a high blood glucose points to tubular damage. The tubules normally reclaim glucose, and if they can't, that's a Fanconi type syndrome. Ketones tell you the body has switched to fat metabolism. Think diabetic ketoacidosis or prolonged anorexia. Bilirubin in dogs, trace bilirubin in concentrated urine can be normal. In cats, any bilirubin is abnormal. And blood on the dipstick, it can't tell you if those are actual red blood cells or free hemoglobin. The sediment will sort that out. Is where the urinalysis really comes alive. When you spin urine down and look at the pellet under a microscope, you're looking at what's physically present in the urinary tract. Red blood cells mean bleeding somewhere. Could be the bladder, urethra, kidney, or even reproductive tract contamination in a free catch sample. White blood cells tell you there's inflammation, which may or may not mean infection. You need bacteria in the sediment combined with WBCs and clinical signs to confidently say infection. Bacteria alone in a free catch sample could just be contamination. And epithelial cells, if they look unusual, atypical, or are clumping together, that's a red flag for transitional cell carcinoma. Always note what you see and correlate it with the collection method and clinical picture. Casts are really special and underappreciated. They form inside the kidney tubules when proteins or cells get trapped in the tubular lumen and take on the cylindrical shape of the tubule. So when you find casts in the urine, you know the pathology is in the kidney itself. They're literally shaped by the tubule. Hyaline casts can be seen with mild stress or fever and aren't necessarily serious. Granular casts suggest actual tubular cell death and are more concerning. Cellular casts, full of red blood cells, white blood cells, or renal epithelial cells, indicate active acute tubular damage. Waxy casts suggest chronic end-stage tubular disease. The type of cast tells you the severity and acuity of renal involvement. Crystals in urine are common and often not clinically significant on their own, especially in refrigerated samples, where crystals precipitate out even from normal urine. But certain crystals are red flags. Urate crystals in a dog that isn't a Dalmatian should immediately make you think about a portosystemic shunt. They form because the liver isn't processing purines properly. Calcium oxalate dihydrate crystals in a dog that got into antifreeze is a veterinary emergency. Ethylene glycol is metabolized to oxalate, which precipitates in the kidney tubules and causes acute renal failure. Bilirubin crystals are abnormal and point toward liver or hemolytic disease. Context always matters. Crystals are a clue, not a diagnosis. Here's your systematic workflow. Step 1. Know how the sample was collected. It frames everything else. Step 2. Physical exam, especially urine-specific gravity. Step 3. Dipstick. Protein and glucose are your highest yield findings. Step 4. Sediment. Look for cells, bacteria, casts, and crystals. Step 5. Correlate with chemistry. And step 6, ask yourself, does the urine make sense given the kidney values? A dog with elevated creatinine and a USG of 1.040 might actually be a pre-renal problem. A dog with elevated creatinine and a USG of 1.010 has primary renal disease. The urine is the interpreter of the chemistry. To wrap up, urinalysis is a three-part test and all three parts matter. Know how the sample was collected before you interpret anything. USG is your anchor. Always measure it with a refractometer. Proteinuria in dilute urine is meaningful and should be quantified with a UPC ratio. Casts are the kidney's way of leaving fingerprints. They tell you the problem is in the tubules. Crystals add context for urolith risk and sometimes flag serious systemic disease. And remember, the urinalysis doesn't stand alone. It's the partner to your chemistry panel. Together, they give you the complete renal picture. Question 1. Female dog with urinary signs and the urinalysis shows protein, alkaline pH, rods, and lots of white blood cells. What's going on? And given how this sample was collected, what needs to happen next? Clinical picture absolutely fits a UTI. Urinary signs, pyuria, bacteriuria, alkaline urine suggesting urease-producing bacteria like Staphylococcus or Proteus. But we have to pump the brakes on treatment because this was a free catch sample. In female dogs especially, free catch urine routinely contains bacteria from the vaginal vault and perivulvar skin. We cannot culture a free catch and reliably diagnose a UTI before we prescribe antibiotics, and this is critical in the era of antimicrobial resistance. We need a cystocentesis sample sent for culture and sensitivity. Treat based on culture results, not empirical guessing. Question 2. Diabetic cat, very high blood glucose and lots of glucose spilling into the urine. How do you explain the glucoseuria physiologically, and how would you know if this were Fanconi syndrome instead of diabetes? Question to think through mechanistically. The kidney tubules normally reclaim all filtered glucose. It's too valuable to waste. But when blood glucose goes very high, as in this diabetic cat, it exceeds the tubular transport maximum. The tubules are working fine, they're just overwhelmed by the load. In Fanconi syndrome, it's the opposite. Blood glucose is normal, but the tubule transporters themselves are broken. Glucose leaks through even though there's not that much of it. Fanconi also typically affects other tubular functions, so you'll see amino acids, phosphate, and bicarbonate in the urine too, not just glucose. The single most important distinguishing test is a paired blood glucose at the time of urine collection. Question 3. Possible antifreeze ingestion 6 hours ago. The urine has blood, calcium oxalate crystals, and Cas. What is the urinalysis telling you, and how urgent is this? This is a genuine emergency, and every minute matters. Ethylene glycol, the active ingredient in most antifreeze, is metabolized in the body to oxalic acid, which combines with calcium and precipitates as calcium oxalate crystals directly inside the kidney tubules. Those crystals physically obstruct and destroy tubules, causing acute renal failure. The urinalysis is already showing you crystals in the urine, Cas indicating tubular injury, and isosthenuria showing the tubules are already losing function. And this dog was only exposed 6 hours ago. The antidote in dogs is fomepizole, which blocks the enzyme that converts ethylene glycol to its toxic metabolites. It must be given as soon as possible, ideally within the first few hours, before metabolite accumulation causes irreversible kidney damage. This case cannot wait.